So you guys are all here because you heard about our lovely lecture on the Makoplasty procedure. Now this is a new state-of-the-art technology, and we're one of the very few hospitals in the state of Georgia that actually have this equipment and are able to do this procedure. So we have Dr. Shane Smith with us here today of Athens Orthopedic, and he is one of our few surgeons that is trained on the Makoplasty procedure and kind of an expert on it. So he's going to be explaining kind of how it works, some of the benefits of it. So maybe you can learn a little bit more and find out if you're a candidate or not. So I will turn it over to you, Dr. Smith.
Good. Thank you. All right. Can we shut the door?
Yep, go for it.
No one extremely claustrophobic, I hope. Okay, good. Room's kind of tiny. That's right. Well, if I say something y'all don't like, y'all can all attack me and I can't go anywhere. So I appreciate you guys coming and taking your time out. This is a very unique procedure that we're very happy that we can start to offer our patients. The actual procedure we're doing is partial knee replacement surgery, and that's been a surgery that we've been doing for a long time. The problem is with partial knee replacements that have been done in the past. Have been that the lifespan of those replacements have not been very long. And so the idea behind this particular technology is that we can improve how we do the surgery, and using the robotic technology and so forth that we'll talk about in just a minute allows us to do that. So we'll kind of just run through some preliminary stuff. We're, as Emily said, I'm a partner at Athens Orthopedic Clinic. I've been practicing here in the area for about five or 6 years here, and certainly very excited about the hospital and some of the new technology that they've brought here with the opening of the new facility. We have also our clinical faculty at University of Georgia, the new medical school over in Athens, as well as one of the medical schools out of Atlanta, which is an osteopathic medical school, the Philadelphia College. So this is the talk. Walk away from knee pain with Makoplasty. The idea behind the Makoplasty is it's knee surgery using surgeon-controlled robotic arm technology. I always find it funny. I normally get at least one question during these talks about, well, Doc, you're talking about this robotic arm technology, and does that mean you schedule the patient for surgery and they come in and have the surgery while you go play golf?
Right.
And that's not the answer. Right? It's surgeon-controlled robotics. So, all right. So first thing, we'll do a few things, just introductory things to talk about kind of what arthritis is and some basic information. We hear about osteoarthritis, but sometimes it gets confused with the other types of arthritis that we can run into. Osteoarthritis is the type of arthritis that's the wear and tear arthritis. That's when you get too much tread worn off your tires, and it's just from the amount of miles that we put on our joints. Compare that to, say, like a rheumatoid arthritis. Rheumatoid arthritis is more of a systemic problem where our joints kind of attack themselves. The osteoarthritis is the wear and tear arthritis. It's a degenerative condition that causes cartilage found on healthy joints to break down. The most common form of arthritis and a leading cause of disability worldwide, according to our academy. 46% of people will develop knee arthritis over their lifetime. So the chances are you or the person sitting next to you in this room have had arthritis. Certainly you and you can. Most everybody can name a family member that's been affected by arthritis. Very, very common. There are different stages of arthritis. When I tell someone that they have arthritis, they come in to see me, Doc, my knee's been hurting. We get some X-rays, and I look at them, and we see that that they have arthritis. We oftentimes have to grade that arthritis. Not all arthritis is severe. Not all arthritis is mild. Sometimes it's in between. But we have different stages. Typically, the early stage arthritis is what we would consider mild disease. And a lot of times that occurs with sports-related injuries, and there are minor defects or minor areas of loss of cartilage. The mid-stage arthritis, or what we classify as moderate disease, oftentimes you see increasing pain, reduced mobility, which basically means you lose range of motion, changes to your lifestyle, and ability to do the things you enjoy, golf, tennis, whatever the case may be. Maybe just walking can be affected. We oftentimes refer that also as partial knee disease, where it only affects a portion of the knee, which is kind of what we're going to steer our conversation to here in just a few minutes. Then we have the late stage disease where it's severe, and that basically means the entire knee is affected by arthritis. You have knee basically all throughout or arthritis all throughout the knee joint. It's a significant cause of disability, severe pain. Walking and stair climbing are often challenging. Oftentimes you can just have pain at rest that is bothersome. And this is oftentimes referred to as total knee disease. It's these patients in the last category that we're talking about that oftentimes need the total knee replacement, which is something we won't get into too much today, but it is important to compare what's appropriate in given situations. So our treatments typically, I always tell my patients, I try to treat all of my patients no different than I would treat my wife or my mother or my dad, and try to save surgery for the last resort if we can. And in that comes things that we can do that are important: weight loss, anti-inflammatory medications, exercise programs, changes in certain activities, and we typically try to reserve surgery for those patients who are unresponsive to conservative treatments. There are a spectrum of different surgical options, and it really just depends on how advanced the arthritis is. We have this MIS stands for minimally invasive surgery, and arthroscopy is a very common surgery that I do a lot of times for patients that are having pain or buckling in their knee, but they don't really have a ton of arthritis, and they may have had a torn cartilage in the knee. Certainly a knee scope is a great procedure to do. Then we talk about, well, what if you have more advanced arthritis and you get to the early to mid-stage arthritis? What are our options? Certainly partial knee replacement surgery is one of the options that we have available to us now. Total knee arthroplasty, which has been around a long time, is a great option. Still, a lot of patients that have this surgery done do really, really well. The problem is that you're doing the entire knee, whether or not you have arthritis in the entire knee. When you get a total knee replacement, the entire knee is replaced. So if you have healthy cartilage, healthy ligaments that are in there, those are sacrificed to get the total knee replacement in. The difference, when you compare that to partial knee replacement, basically you're preserving the healthy cartilage and replacing only the part that is arthritic. If I cover something or anyone has any questions at any point in time, this is meant to be very informal. I welcome questions at any point in time. If you'll just stop me, raise your hand, and I'll be happy to answer as we go along. We'll also have time, too, at the end to answer any other questions as well. Yes, sir?
I got one. On my knee, if I sit down and completely collapse that knee, it'll catch. And I kind of twist it a little bit and clear up the bone. That's the only time it ever bothers me. Is that
and we'll talk about some of that here in a little bit, but those are the symptoms that I'm talking about. Sometimes can be just torn cartilage in the knee. It may not be severe arthritis. It may be. Obviously, you would need to get x-rays and have it looked at, but if it's something that's just torn cartilage, obviously that can be taken care of with a very simple procedure. You go in and scope the knee, get the torn cartilage taken care of. It may not need the more advanced surgeries that we're talking about. So for total knee arthroplasty for advanced arthritis, total knee replacement, we would consider that the gold standard of treatment of arthritis. And that basically means that's what we've been doing the longest. That's what we know has the a long-term good outcome based on patients that have severe arthritis. It's one of the most successful procedures that we do in orthopedic surgery. Long-term survivorship out at 15 years is about 90%, which is outstanding. Limitations, however, it's very invasive. It's a major surgery. Requires extensive rehab. I usually tell my patients to anticipate about 4 to 6 months of recovery time for a knee replacement, and really it takes oftentimes about a year before you really can say, you know what, this knee replacement that I had finally feels like my own knee again. And so it's an extensive period of time. And one of the things that I just talked to you about is that, you know, when you're doing a total knee replacement, you go in and you're removing a lot of tissue that oftentimes is healthy. And And of course, as a surgeon, I'm looking at that, I'm thinking, man, I hate to get rid of this good, healthy cartilage, although that's part of what you do in a total knee replacement. And that's where, in certain cases that the arthritis is isolated, that's where a partial knee replacement is a benefit. There was a study done out of Duke that what was interesting, talking about all these limitations, 88 to 92% of women and men respectively decline hip or knee replacement surgery when offered. And a lot of it has to do with the limitations. I mean, when I tell someone, hey, really the only option is to talk about total knee replacement, well, doc, what am I looking at? Well, you're looking at possibly a year of downtime or not just quite feeling right, or a major surgery that's going to put you in the hospital for a few days. It certainly has that, you get that sensation that's not something I just want to do right now, and that's what most people feel. And so that was an interesting study that they showed that. So now when we get back to talking about the partial knee surgery, when you have isolated arthritis, the partial knee replacement is a good option because it goes to the source of the problem. You can preserve the cartilage and the healthy cartilage and the healthy ligaments and structures in the knee that you would otherwise sacrifice in a total knee replacement. So with a partial knee replacement, it only targets the diseased portion of the knee. It's less invasive than total knee surgery. And the challenges have been that optimal implant positioning and alignment are very, very challenging. And that's why this surgery has been around a long time. We've actually been doing this particular surgery a long time. The problem has been this third comment right here. Optimal implant positioning and alignment are challenging. The reason they're challenging is because everyone's anatomy is different. And these typical protocols call for us putting the components in after you've burned a certain amount of bone away. You replace that amount of bone with a component or a metal or plastic. And oftentimes positioning these are inaccurate relative from this person to this person, okay? So what we have been able to do is incorporate the individual's anatomy, and we'll talk about that in just a second. But if you compare how many partial knee replacements were done in 2009, there were only 52,000 done in the United States compared to 600,000 total knee replacements. And which brings to my attention, and most orthopedic surgeons who care about this stuff, it makes me wonder, well, are we doing too many total knee replacements? And are we, because I see it, I all the time when I'm, in doing certain surgeries, there are cases that I'm thinking, well, going in, maybe this person was a good candidate for a total knee replacement, but then after I'm looking at their knee, heck, they may have done just as well with a partial. And so those are the things that we as orthopedic surgeons have been trying to sort out. And this technology has really kind of helped me in my practice, and I know a lot of my colleagues kind of fill in the gap there of patients who may not need a total knee replacement, but we've got a good option now for the partial knee replacements. So the idea behind this technology is it's a partial knee resurfacing that's minimally invasive, certainly a smaller incision, certainly a shorter recovery time. The hospital stay is you go home the next day. We keep our patients overnight and then you're home the next day. It's using the surgeon-controlled robotic arm system. It enables more accurate resurfacing based on the individual's need. If I have a patient that's a candidate for this, I will send them for a CT scan, special CT scan that we do here at the hospital. It gets plugged into the computer system that helps us run the robot, and we map that procedure based on your need. And so it's very patient specific. And the idea is that it can be performed on any of the different locations in the knee. We usually isolate it to 2 or less compartments. For example, we have 3 compartments in our knees. We have a medial compartment, which if you all look at your knees, it's on the inside part of your knee. We have a lateral compartment that's on the outside part of the knee. And then we have a patellofemoral compartment, which is right underneath the kneecap. And you can have arthritis in any of those locations. If you have arthritis in all 3 locations, then you need a total knee replacement, okay? If you have arthritis that's isolated to 2 or less of those compartments, then this is a good option, okay? And the way that we find those things out is we can get x-rays. A lot of times we can see what we need to with x-rays. Oftentimes if I've got a patient like yourself with a knee that buckles and pops, a lot of times we'll get an MRI, which can be very helpful in determining that. And then oftentimes I will end up scoping, going in with a scope on a lot of my patients, not only to help with the symptoms. A scope can be a very helpful procedure and can buy you a lot of time before you need anything done, but it also gives me some diagnostic information. I'm actually looking with my own eyes at your knee. Where's the arthritis? Where is it not? That way we've got a good plan. If the knee scope doesn't do the trick for us, we know what exactly we need to do at that point thereafter. Yes, sir.
Dr. Smith, on this partial replacement, what, if you have that done, what's the limit before you get back normal and all that stuff?
Usually it's about 4 to 6 weeks. Okay, I've had the last 2 patients I did. I just saw them today in office. They are back to work. Both of them are back to work in 2 weeks. So and they're up and active individuals. One of them works for the city. So so it depends. I would tell you each individual is different. But for the most part, it's a lot shorter recovery time before you're getting back doing your normal stuff. I usually will tell you at least 2 weeks to allow that incision to heal and for your healing to occur. Most likely 4 to 6 weeks is a good estimate there. So when we're talking about where this partial replacement can occur, it can occur in any of those compartments and up to 2. Such as a medial and patellofemoral. This is the inside part of the knee, and then this is underneath the kneecap. This is the robot. And what I'll do is kind of point out to you what I'm looking at in surgery. The robot itself is this here. The monitors that we're looking at, that I'm looking at as the surgeon, the monitor in the back here. The computer system here is run by one of the technical engineers that program the CT scan and incorporate that image into what we're doing on the robot, with the robot. So the CT scan is plugged into this computer system, and prior to surgery, prior to you going to sleep with your anesthesia, I know, and the engineer already knows what your knee is going to need based on what your CT scan showed me. So it gives us a significant advantage of our anatomy and the component positioning, because what we've seen over the years, like I said, this particular surgery has been around a long time. Doing partial knee replacements is not anything new. It's just how we've done them in the past have often led to early failures because we can't get the components just like the way they need to be relative to an individual's anatomy. Sometimes we get lucky and we get it in the right spot and they do great. But sometimes if you don't get the position just right, they can fail at a very early stage, within 5 years sometimes. So what this technology allows us to do is get that within 98.8% accurate. So that basically means that instead of just tossing a dice or tossing a coin and we're getting it right 50% of the time, we're getting it right almost 100% of the time, based on what your anatomy shows us on the CT scan. So it's increased our accuracy with how well we do these surgeries. I always tell my patients, this is not a surgery we've been doing that's new. We've been doing the surgery for a long time. This technology just allows us to do the surgery better. And this is kind of some of the images that I'll see on the computer system when I'm doing some of the burring, and it's a pretty neat thing to see. I have a 3-year-old, and I'll see him playing video games on his little computer, and I think about sometimes when I'm at work, it seems like that's what I'm doing.
He'll make a good
So he'll be ready. That's right. So. The Rio, that's the robot. It assists the surgeon in treating. Sorry. That's okay. It helps the surgeon achieve the natural knee range of motion and allows a level of precision that we previously could not attain prior to this with conventional instrumentation. It's patient specific. It's with the preoperative CT scan that we get. The intraoperative guidance and knee balancing, that's what I'm doing during the surgery. That's why I don't go play golf when you're having the surgery and let the robot do this thing. Let's let's see here, the next slide. This was a video of it, and I don't know I'm going to be able to get that. I don't think that will come up. So what are the benefits of doing this versus, have we seen that this is beneficial to our patients? And that's the most important thing as a surgeon. Are we getting any benefit from this fancy technology? And typically what we see is that we are able to perform the surgery through a smaller incision than a traditional knee replacement surgery. Only the arthritic portion of the knee is sacrificed. We help preserve the healthy bone and tissue. The implants are positioned where we need them to be. So they're optimized with regard to their position and placement, allowing the knee to perform like it should perform. Potential benefits, we've seen improved surgical outcomes. Because we put the implants where they need to be, we have seen less implant wear and loosening. That's what affects the lifespan. If you start to wear the implant out or it starts to become loose, that's what judges the lifespan of an implant. And so if we get it in perfect position, they last a lot longer.
How are they secured?
That's a good question. So basically the bone that we burr away with the robotic arm, we replace that bone with metal and plastic. The metal adheres to the bone with a high intensity bone cement. Okay, so basically when the metal pieces of metal are adhered to the bone, then we slide the piece of plastic that attaches to the bottom part of the implant. We've seen obviously we can preserve a lot more bone. We make smaller incisions. There's less scarring. It's reduced blood loss. Usually with total knee replacements, it's not uncommon to have to need a blood transfusion. It's very rare to have that in this procedure. There's minimal hospitalization. Like I said, most of my patients go home the next day. Rapid recovery, it's less invasive, and the knee feels more natural. And we'll talk about that in just a minute. One of the physical therapists commented on that. But like I was telling you guys, with a total knee replacement, it is oftentimes up to about a year before my patients will come in. They'll say, doc, finally, this knee finally feels like it's my own now. Whereas these partials that we do with the robot system, it's a lot sooner. You're talking about on the order of a few months. They're like, doc, this thing feels just like new. And so that's a major difference that we've seen there.
Well, Dr. Smith,
Yes, sir.
if you do the partial, it takes up to 4 weeks to get over it. After that time, can you climb a step ladder? Or,
No,
I mean, when can you do that?
Yeah, and so what I normally will tell my patients for normal healing or for normal activities such as walking and just daily activities where you're walking without the assistance of a walker or a cane is usually that 4 to 6 week period of time. For activities such as vigorous activities, which I would include like tennis, ladder climbing, repetitive squatting, things like that, you've got to allow time for your quadriceps muscles to heal and strengthen. And that usually takes an additional 6 weeks. So that's about a 3-month time period that we're, especially if you're wanting to do something that's high intensity exercise, whether it's tennis, whether it's bowling, whatever you like to do, or work specific, such as climbing ladders, or you're a mechanic and you've got to get down and on your knees and so forth. So we've got to allow a certain period of time to allow the muscles to get stronger, but from a standpoint of the actual knee being functional to where you can do all your normal activities, that's within a 4 to 6 week period of time. If you were, like I said, if you were an athlete or you're wanting to get back to a sport, I would probably, and that's just me being cautious, it's not that you physically couldn't do those things, I just would prefer you waiting until the muscles build up their normal strength.
But I mean, if we have this done, you'll tell us.
Oh yeah. No, my follow up on my patients is pretty close with any surgery I do, but particularly for this type of surgery, we always watch the implants. We want to make sure that they're staying in the same position. So what I normally will do is have my patients see me at 2 weeks after surgery, then at 6 weeks after surgery, then at 3 months after surgery, 6 months after surgery, and then a year after surgery. And we're getting x-rays all during that period of time just to watch the implants and make sure that they're staying where they need to be. Also, I'm getting reports on a regular basis from our physical therapists. We start physical therapy very early, either as an outpatient or having them coming out to the house for the first couple of weeks with home health therapy. And I'm staying on the phone with them, getting reports from them on a regular basis to keep tabs on how well you're doing and what progress we're making or not making. You know, if there's a complication, we've got to know all that. You know, if you're getting stiffness in the knee, we got to be able to work through all that. So that's a great question. So who would be a good candidate for the Makoplasty procedure? As I said earlier, each treatment is going to be individualized, so not everyone is a candidate. This is a great technology, but there is a specific window of patients with specific arthritis that are candidates. Not everybody's a candidate. Some findings are consistent with patients that are usually a candidate. Knee pain with activity on the inner knee, like if you say, Doc, you know, my pain is always here. That's a trigger in my mind. Hey, maybe this is a person that has some isolated arthritis. Let's get this worked up, get some X-rays, and take a look at it. So pain with activity on the inner knee, under the kneecap, or on the outer knee. And if it's in all those locations, then like it may be more advanced than what we expect. So you may not be a candidate for it. But if it's isolated, that's a good sign that there may be just some isolated arthritis. Startup knee pain. What we mean by that is if you're sitting like you are for however long we do this talk, and you just get up and you're starting to have pain when you get changed positions, we call that startup knee pain. So that's a very common thing that we'll see with patients with mild to moderate arthritis, even sometimes severe arthritis. Failure to respond to non-surgical treatment such as rest, weight loss, physical therapy, non-steroidal anti-inflammatories. One thing you'll learn about me, especially if you come to see me for a problem like this, surgery is not going to be the first thing I offer you. Okay, there are a lot of things that we can do that can be very helpful from a standpoint of controlling your symptoms that may prevent you from needing surgery. Okay, so I always think that's the safest and the best thing to do is try these other measures first. But if you fail those measures, you've had several injections, you've had the physical therapy, we've done the bracing, we've done things that we know are the good conservative measures, and it doesn't work, then that's when the surgery is a consideration. So here's some X-rays, and I'll kind of point out to you. This knee here, they were complaining mainly of pain on the inner part of the knee. Okay, that was isolated. Their isolated complaint. I looked at these X-rays, and basically you can see here. I'm going to point out to you guys. Can you see the space between this is the thigh bone, okay? Thigh bone, leg bone. The space between these bones is our knee joint. The space should be fairly uniform, and it should be fairly smooth. The edges of these bones should be fairly smooth. When the space starts to narrow or the bones become irregular, that's a sign to me that there's arthritis in that part of the joint. And so this part of the joint actually over here looks really good, nice and healthy. But if you look here, you guys can see how narrow this joint line, you see that black line, how it just kind of thins out right in that area? That's the bone getting closer to itself. That's because the cartilage is wearing out. Cartilage doesn't show up on an X-ray, and that's why it shows. You see this black space here. That's cartilage. So if the cartilage is thinning out, the bones get closer together, and that's what dictates to us that hey, there's some arthritic changes going on here in the knee. So in this case, this was isolated, what we call medial compartment arthritis, and so they had a medial compartment arthroplasty, and this is the metal component here is kind of encases the end of the thigh bone, and then the plastic component here kind of sits down into the tibia. Okay. Now this type of implant is a little different. We actually use this version here, where there's a metal component sitting on the tibia. This version here was an earlier version that we found that these tend to loosen a little bit sooner. So we use the metal version where we put a metal piece down here on the tibia. Can y'all see the difference there? And so the plastic that we put in there goes between these two pieces of metal, and that plastic functions as our cartilage. So And then this was an example where we did the medial compartment, but we also did the patellofemoral. So underneath the kneecap, there's a lot of arthritis, and you can see the bright white sign right there. That's kneecap arthritis, and so that's why we replaced that as well. So here's some common questions, and we'll hit some of these too, some of your questions later. But how long can I expect the implant used in Makoplasty procedure to last? This is one of the most common questions that I'll get. All of the implants have a limited life expectancy. It's like any man-made product we can think of. There is a limited life expectancy. It does depend on several factors: patient's weight, activity level, quality of their bone, compliance with the doctor's orders, alignment. With all that said, all that's important. However, we found, like I talked earlier, the alignment and positioning are also very important. That's, in fact, the most important thing from a technical standpoint. Obviously, you've got to watch what you're doing and make sure you get the wound to heal and try not to get it wet and decrease our risk of infection and things like that. Those are things that as a patient, we can help minimize our risks. But as the surgeon, we're looking at the technical aspects of it, and that's where this robotic surgery can really help us out there. So the goal of the Makoplasty is to achieve the absolute best alignment and positioning so we can get the longest lifespan possible out of those implants. Now those implants, when they're positioned appropriately, they can cycle, and we've seen them with a lifespan up to 20 years. I've got a patient of mine who had his done, a partial knee replacement done many years ago. He's going on 20 years now. And obviously we didn't have this kind of technology back then, and I didn't do his surgery 20 years ago. But he actually had good position implant placement, and he's still going on it. I've actually done a total knee replacement on his other knee, and he's still doing good with the partial knee replacement. So I will say this though: he's thin, he's active, he's healthy, and otherwise has been real compliant with his knee. So there's a lot that plays into that. I think that my recommendation usually is if you've got isolated arthritis, the partial knee replacement is a good option, for the main reason that you don't really burn any bridges. If you do have a complication with it and it does loosen after 10 years or 15 years or whatever the case may be, you don't burn any bridges. You can always go the route of the total knee replacement if need be. So that makes another advantage to it.
Dr. Smith,
Yes, ma'am.
when I told my brother, who is a doctor, about my condition,
Mm-hmm.
and I told him that it hurt on the inside of my knee, and that's where you dealt with my knee,
Mm-hmm.
he said, that's very unusual. He does not know what you know. He's not that kind of doctor.
Okay.
But he said that's very unusual because it's usually men that have the inside problem.
Now, well,
and the outside.
he's actually on to something there. So basically what you're getting at though is the way men and women, their alignment is usually different.
Right,
Okay?
that's what he was saying, the way they walk.
That's right. So men typically will have what we call as a varus knee, and that's where their inside part of their knee will start to wear out before the outside part
Right,
does,
okay.
and that'll give you that little bow-legged appearance.
Oh, it's inside.
That's what we call as a varus knee, and so that's what he's referring to. That's more common to see that in men. Now, women can have either, obviously, either direction, but we do see where women tend to get a little more valgus, and that's where you get a little more knock-kneed appearance. It's not the bow-legged, it's the opposite. You get a little knock-kneed appearance.
Right.
And so that he is exactly right. But I think what he was probably gathering is that he was more talking about our alignment as males and females.
Right.
And so now with that said, just because you may be prone, if you're a female, and you may be prone to have the knees come in, doesn't mean you can't still have isolated arthritis in one location. And so that's the thing to kind of make sure of. So
Well, you want to know what kind of doctor he is?
sure.
He's a dentist.
Okay.
73
Fair
years
enough.
old.
Well, you know what? I'm very impressed now that even the dentist knew that. That's good stuff.
Dr. Smith,
Yes, sir.
I done been to you one time. And when I get up out of the chair or off the commode, if I put my hand on my knee, it sounds like rocks under there.
Yes. Chances are it's that's what we call that. That is crepitus. Okay, crepitus is that grinding sensation that you feel in your knees. 9 times out of 10, and what I will do oftentimes is in the office, I'll put my hands on the front of the knee and make that knee go back and forth, and you can feel it.
Yeah.
If you have that, 9 times out of 10, it's because of arthritis underneath the kneecap or in the groove where the kneecap travels. So that's very very common to see. So with that said, X-rays can certainly tell you that and lead you down the path. If you've got isolated patellofemoral arthritis, or if you've got other areas that are affected, then that would show up on the X-ray too. So, all right. So what are the benefits of this new technology? We've talked about some of those. It's minimally invasive, more rapid recovery, natural feeling knee. Results have shown that it potentially allows for patients to experience a shorter hospital stay, minimal blood loss, quicker rehab, and a smaller scar. In addition, many Makoplasty patients are able to return to an active lifestyle within weeks of their procedure. I like this. One of my physical therapists sent me this picture. And what are the benefits of this new technology? I always say, this is what we want, And although this is a nice walker, we want to be independent. We want to maintain our mobility and maintain our active lifestyles. So here's some comments from various patients that have had this done. It's fun to read through these. The pain was keeping me from walking. I couldn't walk, but from one room to the next. This is such a pleasure to have this surgery, and recuperation was so speedy. My physical therapist says she has never seen such rapid muscle response. I was recently able to walk 3 miles, and that included some hills. I had no difficulty with the knee. This is an interesting thing to say, and the reason that the physical therapists, they don't see this kind of rapid muscle response is because we're not messing with the muscles. We're isolating the surgery we do to the affected area. So that's why it's such a rapid recovery. Sometimes when I'm walking, it feels so comfortable that I have to stop and think which knee has an implant. That is the point in time when you know that knee is yours, and that's that comfort zone. And most of our total knee replacement patients will get to that point, but like I said, it's such a long period of time after, almost up to a year. I'm now able to go up and down steps without holding onto the railing, totally pain-free. I no longer feel limited or cautious because of my knee pain and discomfort. Now I can do just about anything and everything I want, all physical activities except running. And I will say that that's one of the controversial areas that I try not to encourage. Running is a high-impact activity. Like we were talking about tennis, I have some, I can't.
Step ladders.
Step ladders is not as high impact, and it's probably okay. But as far as if you were jumping repetitively off that step ladder and jumping down, I would say that's a no-no. Jumping and running are typically, that's the way to wear out the implant fastest. So, any questions?
Stay off of the treadmill.
Well, the treadmill is actually good if you're not doing a lot of high impact. The walking on the treadmill is certainly fine. But if you're doing jogging or running, it's kind of like jogging or running anywhere. You're putting a lot of impact there. So, any other questions?
So I had to give up my jogging, huh?
If you were to have that done, I typically don't recommend that. It will wear out that implant a lot faster if you're doing a lot of high impact stuff.
Well, Dr. Smith, I ain't been able to squat in a long, long time.
Well, I tell you, and squatting from what you've described to me is that is the arthritis underneath the kneecap. That's what's preventing you from doing that. Is squatting, stair climbing. Oftentimes, that's what you'll see with pain and arthritis underneath the kneecap. Difficulties doing those types of
It
activities.
seems like when I step off a curb up on the sidewalk, I have to almost jump to get going.
Yeah.
And your point is, we all respect it.
Well, I think we have a tendency to tell ourselves, well, that's just a normal thing. I should
That's
expect
right.
that as I get older or whatever. But that's not always the case. If it's something that's bothersome or getting in your way or causing problems where you need, get it checked out. You know, it's there's a chance that first off, it may be something very easily taken care of that doesn't require any of this surgery that we talked about. It could be something that, you know, with a little cortisone injection or some little physical therapy or just doing some things that are non-surgical that can be very helpful. So don't feel like you gotta live with it. You know. Yes, sir.
Dr. Smith, I got a neighbor, she had both of her knees replaced at one time. And she didn't have no problems, and she said she knowed that, she'd done it 20 years ago.
Yeah. Yeah. And I will say with my patients, whether they're the partial knee replacements or total knee replacements, that's a very common thing. It's most of my patients are, especially that 1 year out, they usually say, Doc, you know, I wish I would have just had this thing done many years ago. And I think our tendency is we just kind of try to deal with things. It's our human nature to just try to deal with the pain and kind of push through and keep doing your thing. And the point is, you know, there are some very good things that we can do to alleviate that and help you preserve your activity and your lifestyle. So, yes,
You
ma'am.
know that the steroid shots are not good for your bones. Excuse me. How long is it safe to take the shots
That
rather than the
is a great question. And you'll see a lot of literature out about that. And what I typically will tell my patients, I'm very conservative. I limit the number of injections that I'll do for a specific problem. I will normally say no more injections than one every 4 months. So basically 3 injections a year is about all we'll do.
But for how many years?
Well, and there hasn't been anything shown that you couldn't do that for 10 years. The point is that the small amount of cortisone that we put in, we're not repetitively putting that in every 6 weeks. Okay, your body has time to eliminate it, and I always say it's, you know, cortisone is like anything. You know, you can get too much of a good thing, and cortisone is definitely one of those things. And so you've got to be very cautious with it. But you know, if you're getting an injection once every 4 or 6 months, you know, we haven't seen any major issues with you know, bone strength or anything like that.
Dr. Smith, you gave me one some time ago.
It's been a while.
Huh?
I think it's been a while.
No, it ain't been all that long.
A few months.
No, it's been sometime between now and the other side of Christmas.
Okay, so about
But
a month.
anyway, I ain't never had no problems hurting. It feels like when you get up off the commode, it feels like rock to rock
Yeah.
or a
That's
chair.
right.
Say the truth.
And it seems like when I'm going down steps, if I don't hold something or take one step at a time, it feels like it ain't gonna hold me up.
So what you're describing there is you're still having the mechanical symptoms, even
Right.
though the injection has helped with the pain. The mechanical symptoms are still there, and that's what we've got. We need to get back together at some point, and we need to
I
take a
ain't got
look
an
at it.
appointment with you.
All right, good.
Why are you a sports doctor?
Well,
It says sports doctor.
yeah, my specialty is sports. Basically, sports involves knee and shoulder is kind of our specialty areas. When you see someone that's a sports, we have several sports guys that are in our practice. Sports involves a lot of knee and shoulder work. Basically, I did an extra amount of training to get that sports training. I, like other orthopedic surgeons, still will do a lot of fracture care, the joint replacements or hip replacements, and fracture care like trauma. You know, a lot of hip fractures and ankle fractures and things like that, wrist and forearm fractures and so forth. We still will do a lot of those surgeries as well. But kind of my area of expertise is knees and shoulders, and so pretty much any surgery around the knee or shoulder is usually what we would specialize in.
Well, I will be your challenge because I have a titanium rod in my right leg, my femur,
Mhm.
and hardware. And you didn't know if you could cut off the femur.
That's right.
So,
Well, as far as doing the knee replacement surgery, is that
doing
what you-
anything, I have arthritis.
Yes,
I know
that's
right.
what I'm talking about. Because when when you're doing a total knee replacement, if the hardware goes too far down,
Right.
then that's what you've got to worry about. Well,
I
does
know.
is your knee going to tolerate that?
Right.
You know, and are you going to have enough bone to work with? So that's always a challenge. You're right.
I know. I'll be your challenge.
Yes, sir.
Dr. Smith, do you do that here at this hospital?
Yeah. Oh, that's a good point. That was a good question. So where do we do this surgery? Our practice, all of my partners who do this, myself and I think there are 3 other guys in the practice that will do this surgery, we all do them here. We are one of, I think, 4 hospitals in the state that have the robotic technology. There's one on the other side of Atlanta, there's one in South Georgia, and I think there may be one in Savannah or somewhere. I don't think Augusta has one. Anyway, we're the kind of the closest robot to this area.
Okay.
And even the Athens hospitals, they don't have that. So a lot of our guys in the Athens area will come over to do the surgery here. So,
Okay.
yes, sir.
Is there any real benefit from any of the supplements, joint supplements?
That's a great question. Yes, there is. Now, some people get a lot of benefit from them. Some people get very little benefit. So again, that's one of those treatments that's going to be very individualized to your specific problem that we're treating. So the supplements that we're talking about, the glucosamine and chondroitin, that's the one you'll hear most about, I think is a very good joint supplement. And there are different ways that you can take it. There are liquids and pills, and they've got a variety of different things that you'll see in the pharmacies and so forth. And certainly is a good thing. We've seen that it's more effective for patients who have mild arthritis, mild to moderate arthritis. Once you get severe, it's not as beneficial. The other types of injection, we've talked about cortisone injections, but there are other types of injections that we do also that can be helpful. They're called viscosupplement injections. It's basically where we're kind of injecting cartilage nutrients into the joint that gives some bolstering effect to the cartilage that's there, to the healthy cartilage that's there. So you may have heard of Synvisc, Supart, some of those types of injections. And those can be helpful also. All right. Well, good. Thank you, guys. I appreciate y'all coming. Yes,
I
ma'am.
have one other question. What about the injection from the rooster?
That's what I'm talking about. Yeah, you hear the rooster comb injection. That's exactly what we're talking about. That's visco supplementation. It's Synvisc, Suparts, a lot of those injections, and that's where it's high algin is another.
Is it, with your patients, how many have had success with that?
It's about 60 to 70% will get long-term relief for about a year or more. So it's fairly good. The problem is that it's very expensive, and there are a lot of insurance plans that just won't cover it at all. And it's a shot that can cost up to several $100s. So what I normally will do is before we go that route, I will try cortisone and see if that is a successful regimen that we can try. If it gives you temporary relief and we see that the Synvisc is something that we need to try, then we'll get it approved with the insurance and make sure it's covered before we try to embark on that expense. So, but it's very, very good options for us, and we do see that a lot of people get good relief from it.
Well, thank you so much for coming, Dr.
Yes,
Smith.
ma'am.
And if any of them want to follow up with an appointment with you, what is
Yes.
the number at the office that we can reach
Yes,
you
I
at?
had, now so 770-267-0978, that's our office number. Now it'll ring into it should transfer over to the Athens office, and all you got to do is say, hey, I want to see Dr. Smith in Monroe, and they'll get you set up for that.
Loganville.
Or Loganville, wherever's convenient. We see patients in Monroe, Loganville, and Snellville, and also Madison. So we've got kind of 4 offices out in the western hemisphere is what we call it. So, and then of course we've got offices in Greensboro, Athens, and then north of Athens as well, in Royston and so forth. So, all right, guys, thank y'all again for coming out. I appreciate it. It's good to see y'all.